panel session today.
And I'm delighted to be able to welcome as our final speaker Ciaran Devane. Ciaran's the Chief Executive of Macmillan, which, as you will know, is one of the largest and most effective charities in the country. Ciaran is also a non-executive director of the NHS Commissioning Board, NHS England, and Ciaran's going to be talking to us about innovating in health, partnerships, third sector approaches, and keeping a check on the centre. Ciaran, welcome.
Hello Andy, hello everyone, hello back. Right, this is going to be a little bit of a chat of gossip. I'm going to try and not talk at you for a lot of time, maybe talk for 15 minutes or something. And we don't sell to the NHS. We don't sell things to the NHS at least. What we do is we sell ideas. So what I want to talk about is a bit of what we think we've learned by working with the NHS across the UK, different levels, government, etc. So hopefully that will be interesting, helpful, useful in some way. Page down, nothing happens. How about arrow? There we go. Okay, a little bit of history, because it helps set the context for the charity. This is a guy called Douglas Macmillan. He didn't name it after himself. But he set up the charity when he watched his father die of cancer back in 1911. And he was 24 years old, he was a geek.
Sorry.
Oh,
Do I need to be, you can't hear you quite so well? Just
nearish the mic. Nearish the mic, my apologies. So when his father died, he'd had this opinion that cancer only happened to bad people. So he had to make a decision, well, am I wrong, or is my father a bad person? And he decided he was wrong. So in amends, he started looking at data. So he went through every death register in the United Kingdom from 1850 to 1910 and started plotting things. And it was out of that he said, this cancer thing is going to be more important. And one of the big posters he developed was this one up here, which was saying, if you compare the number of deaths we're having in this country now in 1911 against tuberculosis, cancer's the big one, it's not TB. So he started saying, this is the disease of the future and something must be done. So he set up this charity, and and it's evolved through time, is my real point here. So, Macmillan Cancer Relief was the name for a long time, and then this red blob here, don't know what they were thinking in the 70s, but it was for a lot of things. But the charity changed. So it changed from being this campaigning organisation really up until after the Second World War, and then the hospice movement begins, and the NHS is invented. So the charity had to decide really what was its role in this emerging thing. So if you roll the clock forward and you end up in 2007, which happens to be the year that I joined, the charity had changed its name to Support Not Relief, because relief had this Victorian famine relief connotation. And we've done a piece of work which said our ambition is to improve the lives of everyone living with cancer in the UK. But there were two problems with it. We didn't know what improve meant, and we didn't know who everyone was. Let me explain that a bit. As an organisation, we were largely a nursing-led organisation, but what nurses think patients want is not necessarily what patients think they want. Same with doctors, same with health service managers. So the first decision really that we did was, well, let's work out what people out there really think that good care looks like. And we ended up with this, which is a long way from an outcomes framework, or the mandate, or everything else. It's saying, I quite like to be diagnosed early, I want to get good treatment, I want to understand, I want my family looked after if I can't work, because I'd rather pay the mortgage than not. So we started saying that actually what we need to deliver, as a charity, but also as a system, is not just technically brilliant healthcare. And if you look at a lot of the stories we've been dealing with over the last while, stats is one of them. Now, you can either believe standardised hospital mortality rates or not, but the thing that absolutely you could understand and get your head around was the poor care and poor experience. And that's what people out there really worry about and really want. So we developed this framework. We said everything we do as a charity needs to be aimed at one of those 9 things. We don't have to do everything in each area. We don't do screening, for example, but we do worry about supporting GPs with diagnosis. But everything had to be targeted at that. And the second thing was trying to answer this question of how many people was everyone. Now, I'm an engineer, I'm a geek as well, so I like understanding the numbers. If we're talking to the NHS in Hampshire, I think we need to know how many people in Hampshire are A, alive, B, have a cancer diagnosis, which cancer diagnosis, how long have they had it, what problems which proportion of them have. But of course, one thing that we didn't have was a prevalence number. We counted how many people were diagnosed in the country, we counted how many people died of cancer in the country, we didn't count how many people with cancer didn't die of cancer and died of something else, and we didn't count the inventory in the first place. But when we did the numbers, and we we're blessed in this country in having cancer registration, it's a notifiable disease, when we actually did the work, it said two things. The first thing it said is the answer is 2 million people. That's a lot. But it also said it's 2 million and growing, and had been growing at about 3.2% a year since the early 90s. Now, if you just draw the graph, it says by 2030 we're going to have 4 million people in this country living with a cancer diagnosis. Now, that changed everything, because whatever chance we had of doing the right thing for 2 million people with cancer, whether you're Macmillan or the NHS or the government or anybody else, 4 million people within your planning horizon means you can't just ask the NHS or anyone else to run around the hamster wheel twice as quickly. You're going to have to fundamentally change the model. So that was the second bit of thinking. So we stepped back and we said, right, what's our role in this? And the first thing we said is we have these principles. The first principle is we're about innovation. We are not about having contracts with the NHS. We don't want to be commissioned ourselves. Now, there are two reasons for that. The first one is, you know yourselves, the first thing that happens is, can we have 10% cheaper, please? Instead of giving us this, can you just give us this thing over here as well? So you end up not quite doing what you want to do. But the second thing is, it completely changes the power relationship. Because having said we sell ideas to the NHS, not only do we sell the ideas, but we walk in with the money as well. So we say, we think you should be doing this, we will pay for it, but we'll only pay for it for a while because it's not a job to underwrite you either. And then once we've demonstrated it's a good idea, then you pick up the cost when you sign a piece of paper saying you're going to pick up the cost. And then we'll have the next conversation with you about the next improvement and the next innovation. And what that allows us to do is make sure that we spread the pound in the tin as effectively as possible. But it also allows us to leverage things. It's not, we don't just get one. We might pay for something for 3 years, but the NHS will pay for the next 12. So that's quite good leverage. And the other principle here is, it comes from those outcomes. We are acting on behalf of patients and their families. We are not there to defend the NHS, which is why you see, stories in the newspapers where we're saying kind of not okay that cancer outcomes in the UK are amongst the worst in Western Europe. But it also puts us in a position where influence is important. Let me try and explain that. This is my favourite slide. We've grown quite a bit over the years. In fact, we've grown so much, we've turned into that little green dot over there. The next blob is how much the NHS spends on cancer in the UK. So we're 1/60th of what's spent. So we could be really, really good, and we could grow our blob a little bit bigger, but we'd be 1/58th of the big blue circle. And what that means is that, back to this leverage idea, not only do we have to spend the pound in the tin really well to have maximum benefit for the person we're supporting, but we have to tell people, look at this great service over here. We'd quite like to spend some of your 6 billion on this as well. Copy us, please, so that our impact is that much bigger. And the next thing it says is actually, even if people copy us, there's everything else that they do as well. We need to influence that. We need to be in that room. We need to be telling people what good and great is. And by the way, there's this other 125 billion that we spend in the UK on health as well. We'd quite like to influence that as well. So our job isn't only to provide very good services, it's also to talk about it. It's also to get people to replicate it using their money. And it's also to allow us to spend their 6 billion, 7 billion, in the way we think is helpful. So our influence agenda is at least as important as our actual service delivery agenda. And that's what brings us into the things I think we've learned about how do you influence the NHS. We were the people who came up with that prevalence number of 2 million and 2 million growing to become 4 million. We recently published this document, which is a report on how is the UK faring against each of those 9 outcomes. So the first thing for us is, if we are going to be effective in selling our ideas, in getting people to replicate what we do, in allowing us in that room to influence the decisions, is we have to know more about cancer than they do. So our policy people need to be better, our data people need to be better. And that's the first thing. So hypothesis 1, if you're trying to get NHS people to do what you want to do, you need to know more, you need to tell them something they don't know, and that gets attention. And the next thing is to have a clear strategy. This is Macmillan's strategy, and it fits on a tweet. It's precisely 140 characters. If your organisations can't do that, you're just not cool. So what's our strategy? It's saying is deliver those 9 outcomes. Seems obvious. I'm sure the word variability probably came up. How come we do something in one part of the NHS and we don't do it in another? Well, actually, one of the things we have to achieve is do the things we already know are good. We know that if you have a Macmillan nurse or somebody who looks like one, that your experience through cancer is better than those who don't. So if you don't have one, you should have one. Build great community services. All the talk, which again, I'm sure came up during the day around supporting people to do well and out of hospital is at least as important as dealing with people elegantly when they have a crisis. So we need to get out there. And that's a challenge for us because we're good in 200 buildings called hospitals which do cancer. We need to be good in every town and village. And even if you do that, it's still not enough. There are 3 things we think have to be radically different. The first one is the days of incremental improvement are gone. We have to have a radical change of the NHS, we have to have a radical change of cancer services. So whole system change. We need to, if you want to be unkind about Macmillan, you'd say we're brilliant at product selling. We think you should have a Macmillan nurse. You don't want one of those, I've got a really nice occupational therapist you should have instead. What we need to do is go and say, actually, we want to fix all of breast cancer in all of Manchester in one go, because that's the way you get the benefit. And that's a real challenge, which I'll come back to. The second thing is the workforce is going to be very different in the future. There are not enough people coming through nursing careers to fill the roles that will be needed for the 4 million people. There just aren't enough. We didn't start training them 15 years ago. We're going to have a problem. So we need to think of different ways of, so what's the next incarnation of the Macmillan nurse? Maybe they're not based in one of those 200 hospitals. Maybe it's your practice nurse with some extra skills. So we need to think through all of that. And the third one is saying, what's our role? Most people don't want to be treated like a disease or a tumour or a patient. So I'd quite like to self-manage. So when my wife was ill with cancer, we did almost everything we could. And we were fortunate, we had nice employers and we could waive a credit card at the problem sometimes. But that's what people want. They want to be autonomous. But how do we give people the skills to know, actually, this is okay, there's something funny here, I need to get back into the hospital. And then the last bit is kind of this thing about we have to influence other people as well. Just want to give you some examples though. First one around whole system change. We have the thing called the National Cancer Survivorship Initiative, covers England, not the UK, which myself and the National Cancer Director chair. And what it's saying is we want everywhere in England to do the aftercare of cancer patients in a completely different way. Because what the traditional model is, you get a diagnosis, you turn up, you have surgery, chemotherapy, radiotherapy, and then off you go. But what we know now is that people have long-term effects from their chemotherapy, double the risk of a heart condition if you had chemotherapy for breast cancer. We know that a lot of people who've been treated have colorectal cancer, for example. A quarter of people are hospitalised for incontinence at some point. Now, we never knew that before until we dug into the data, because we never had a cohort of people who lived long enough to do the data. But that says how we do the aftercare of cancer is really important. Not only for the human being, but actually, that's where the money is. That's where the spend is. It's the 15 years you spend with incontinence which cost the taxpayer a lot of money, not your original surgery. So we need to rethink economically, but also for the sake of the patient, how we do things. So whole system change, not incremental change. The next bit is around doing things in the community. I said we're good in 200 buildings, we've got 200 information centres, but actually people spend more time in booths than they do in the Macmillan Information Centre. So how about talking to booths and saying, would you mind if we trained your pharmacists in signposting people to the right places for cancer support, and would you mind if we put some information into your store, and by the way, would you do some fundraising for us as well? And the third one is back to helping people to help themselves. These are Qigong classes taking place in the libraries in the Gorbals in Glasgow. Now, who would have thunk that that was a very good cancer intervention which rehabilitates people after treatment, gives them some confidence back, helps them get back into work, helps with those longer term consequences of the treatment. And by the way, some of the things we do to ourselves which cause the first cancer might well be what causes another cancer later on. So whole system change, redesigning the system, workforce, helping people take control of their health. But my point really is what those things have in common. Macmillan isn't really doing them. We're doing them in partnership with other people. So what we realised is that our core competence, if one bit of it is know more about cancer than everybody else, the second bit of it is we need to be better at collaboration than everyone else. Because if you grew up in the NHS, you have been living in a command and control system for a very long time, and you're used to delivering improvement. As long as you control the budget, you've got very clear targets, you've got all the resources you need, and you get on and do it, and you report back every 3 months as to how you do it, and you put your point on the graph. In the new world, people are very dislocated. They don't control the resources. They do have to convince a health and wellbeing board or a CCG or Director of Social Services to do what they want to do. But they've got 30 years of not having that skill. So what we realised was if we invested in making sure that our people are brilliant at collaborating, are brilliant at convening, brilliant at influencing, then we're in that room where the 7 billion is being spent and the 120 billion is being spent, and people want to talk to us. So we've invested a lot of money, not in cancer education for our staff per se, we've done that too, but the bit that makes the difference for us is our people are better at strategic influencing, better at multi-party negotiation. So when we wanted to fix breast cancer in Manchester, people came, it was a very well-run process, and we're launching it very shortly. So that makes the difference. And then there's political influencing, which I won't go into, but just you all know there are 4 national health services, not one. But again, it's around saying if we can leverage a change in the law or a change in ambition, then that saves an awful lot of Macmillan's money. It's the shortcut to some of these things. And the very simple example is carers. We worry about cancer patients, but we want to worry about their carers as well. Problem is we don't know who they are. It's relatively easy to work out who the cancer patient is. So when the care bill went through, we lobbied and got something put in which said actually there's a duty on the NHS as well as on local authorities to answer the care bill. That saved us an awful lot of walking around the country convincing people that identified carers was a good thing. Now there's a legal duty. So for me, if you accept the hypothesis that what we do is we sell ideas into the NHS, I think the 3 things I would suggest are that the first one is you have to tell people something they don't know. You have to know something about the topic, which makes them go, that changed my thinking. The second one is saying that you have to have a clear model of how you're going to affect the change, and then you have to be better at those change skills than the people you're talking to, or know more about the topic and be better at convening that debate, hosting that debate and leading that debate than other people. Be at the centre of things. That's what we think we learned. Thank you.